Hi, everyone, and welcome to the cardiac content review. This will cover the concepts that will be on the third exam. The first concept that we're going to cover is right versus left-sided heart failure. And to think of the symptoms that you'll have with both of these types of heart failure, you're going to want to think of the anatomy of the heart, where the blood's going and where the blood is, how is the blood returning to the heart. So for the left side, you're beating, or the heartbeat perfuses blood to the body and then returns to the right side. On the right side, the heart beats and the blood goes to the lungs and it returns to the left side of the heart. So if you have right-sided heart failure, your heart is not beating enough and the blood that is returning to the body backs up. So you're going to have edema to the body. Now, this blood will then be pumped to the lungs and return to the left side, and the left side will beat it to the body. So if you have left-sided failure, the blood is backing up into the lungs, causing pulmonary edema. People cough, they feel short of breath. They need the head of the bed to be up when they're sleeping to breathe. Whereas the right side, the blood is coming from the body, and because it's backing up, you get lower extremity edema, you get hepatomegaly, you get ascites, basically fluid overload in the body. And this picture is showing left-sided heart failure. Again, this would be blood backing up into the lungs without a good contraction going into the body. And this is a picture just to help you remember. You can see on the left, you have the left-sided heart failure. He's short of breath, he's wheezing, he's having a hard time with activity. Whereas right-sided heart failure, her legs are swollen, her belly is swollen, the body retains fluid because the fluid is backing up because the right side of the heart can't pump it fast enough. So as we're talking about difficulties the heart can have with blood movement, there also can be structural problems, as you can see in the congenital condition tetralogy of Fallot. Now, tetra means four, and tetralogy of Fallot has four heart problems. There's an overriding aorta, there's pulmonic stenosis, there's a ventricular septal defect, and right ventricular hypertrophy. Those are the cardinal findings with tetralogy of Fallot. Now, as we approach our coronary artery disease unit, we need to know the difference between HDL, the good cholesterol, and LDLs, the bad cholesterol. Now, bad cholesterol, LDLs, and very low density lipoproteins get embedded into the intima, the vessel layers, causing plaque, whereas HDLs, the good cholesterol, takes it into the liver and then gets eliminated. Atherosclerosis is a chronic inflammatory condition that results from endothelial damage and chronic inflammation. So the first thing that happens is there's an injury to the endothelial cells that line the arterial walls. This can be increased with smoking, age, hypertension, and diabetes. These injured cells become inflamed and can't make necessary antithrombotic and vasodilatory factors. The LDLs that we discussed before penetrate the arterial damaged walls and become trapped. This causes inflammation and oxidative stress, as well as activated macrophages to oxidize the aggregated LDLs. The oxidized LDLs combine with inflammation, causing adhesion molecules which bind to the monocytes, inflammatory, and immune cells. From there, the monocytes become macrophages as they penetrate these vessel arterial walls. And these macrophages engulf the oxidized LDLs, creating foam cells. Now, as these foam cells aggregate, they create a fatty streak and combine with enzymes to further injure the wall. All of this stimulates growth factor, which ultimately stimulates smooth muscle proliferation in this vessel. And these smooth muscle cells create collagen, which migrate over the fatty streak, forming a fibrous plaque. So now that we've talked about plaques, we must talk a little bit more about stable versus unstable plaques. Stable plaques are older and harder due to calcium deposits. They're not growing, and this typically causes stable angina, which are the signs and symptoms that result from the decreased diameter of the vessel, with a decreased amount of blood being able to pass through them. Unstable plaques are soft plaques which contain inflammation and thrombotic activity. These soft plaques are initially the culprits in acute coronary syndromes. Now, with any suspicion of an acute coronary syndrome, you need to get cardiac markers, including a troponin and EKG and an EKG. The diagram above shows the different findings that you'll have with coronary syndrome, such as unstable angina, acute ST elevation MIs, non-ST elevation MIs, and then just other syndromes you can have without having it be acute coronary syndrome. One heart problem that you can have that also presents as chest pain is pericarditis. And this happens where the sac that encloses the heart, or the pericardium, becomes inflamed for multiple reasons. This can happen, and this will be exhibited by shortness of breath, intense, sharp pain, and you can actually hear a friction rub when listening to it with your stethoscope. Another acute cardiac issue is a pericardial effusion. And what happens here is that pericardial sac around the heart, it gets filled with fluid in between the pericardium and the heart. Now that fluid could be blood, it could be any type of liquid. And as that fills up, the heart no longer can expand how it should, and therefore that decreases how much blood it can pump out of the heart. Another issue with the heart can be a problem with the valves. In the picture, you see the mitral valve, and that's the valve in between the left atrium and the left ventricle. Now, if this valve is leaky, you can have blood protrude up into the left atrium with the heartbeat, causing pulmonary congestion because the pulmonary blood cannot get back into the heart how it should. This also can cause problems in that there is now less blood flow being pumped from the ventricle into the aorta, going to the rest of the body. Another valve issue that you'll see in cardiology is endocarditis. And what happens here is bacteria or fungus or any kind of vegetation settles itself on the valves, causing problems as to how they can function. Another issue here is now that you have this vegetation on the valves, they can now freely be pushed into the blood supply and throughout your body. Now, shifting away from the actual cardiac component, we'll get into the vascular, which hypertension is a major component to vascular issues. And in the pictures above, you can see all the various problems you can see in or that develop over time with hypertension. So even when the patient feels fine, their blood pressure still needs to be treated to prevent some of these issues listed above. There are many components to blood pressure and blood pressure regulation, as you have read. You have the kidneys being involved in the RAA system. You have your brain sending the signals out. You have baroreceptors. The above diagram goes into the multiple components of blood pressure regulation. Another vascular issue is chronic venous insufficiency. And in the picture above, you can see the hallmark finding of those discolored lower legs with swelling. Now, as chronic insufficiency worsens, you can have ulcers developed, seeing as that edema prevents good blood supply, including the inflammatory agents, to infections and lesions to ultimately heal them. Now that we've talked about the venous insufficiency, let's talk about arterial disease. Now, in the above pictures, you can see when the vessels narrow from plaquing that there's less blood flow to the tissues distally, which causes them to become mottled and cold and can be quite painful. Another issue you can have is clotting off of one of these arteries. Now, in the setting of a clot, you can see what that vessel would look like at the lower left hand there, blood is not getting to the distal tissues, which will mean they'll start to die. This is an acute problem which needs acute intervention, whether it be a thrombectomy or surgery. But if you can't find pulses, the limb is cold and painful, further investigation is needed promptly. Another vascular issue is an arterial dissection. This can happen to the artery as well as if an aneurysm forms. The key point here is a dissection where there's a break in the vessel wall where blood is allowed to go in and start to pool, decreasing the diameter of the lumen of that vessel. This can ultimately cause an obstruction, and if it does, there will be no blood flow distally, so this can be an emergent condition. The above picture discusses the difference between diastolic heart failure and systolic heart failure. And the major difference is, as you can see, the diastolic heart failure, the heart has become thicker, but it's also stiff. It can't relax enough to let blood get into those ventricles to push out. So there's a decreased function due to its inability to relax because it's so stiff. In systolic heart failure, as you can see in the picture, there's thin heart muscles and they're weak. So the heart can relax and fill up, but it doesn't have the strength to expel that blood out to the rest of the body with the force that's needed. The final concept that I'll be addressing is cardiomyopathy, and this comes in 3 different types. It comes in hypertrophic, dilated, and restrictive. Now, the dilated cardiomyopathy picture is to the right there, and you can see that heart, all the chambers are huge. The muscles are thin, and basically the muscles are not strong enough to beat against that dilatation of those chambers, so not enough blood can get throughout the body with the force needed. Now, dilated cardiomyopathy is a systolic disorder. Restrictive and hypertrophic are both diastolic disorders because there isn't, the relaxation is impaired. So as you can see in the middle picture, that hypertrophic heart is all hypertrophied. Look at that muscle of the left ventricle. Almost no blood can get into that ventricle to pump throughout the body. And therefore the body doesn't get enough blood. And the blood backs up from wherever it's coming from because it can't pump enough of it out. Now, if the blood is coming from the lungs, you'll have dyspnea and shortness of breath. If it's coming from the body, you'll have hepatomegaly, ascites, lower extremity edema. Now, dilated cardiomyopathy is a systolic dysfunction, whereas the hypertrophic and restrictive are diastolic, seeing that left ventricle can't relax how it should.